so that 5 to 5:30 we can do a little bit of a review or ask questions. So be thinking of those things. If it doesn't get done, I'll find another way to help you guys out. And then I've got to take off about 5:30 tonight. So, all right, so getting started, cardiogenic shock. Obviously, we're going to kind of talk about the cycles of it, what's the causes, signs and symptoms, because we always know we get test questions on those. How's it going to present? What's our treatment? And we'll talk a little bit about in-hospital management. You guys can all read definitions here, so I'm not going to go over this too much as far as things. Well, I can see it. All right, so yeah, I don't. Okay, there we go. Cardiogenic shock, because I am recording this here. So there's our cardiogenic shock. These are everything I just talked about: causes, signs and symptoms, presentation, treatments, and here's our definition. So we've gone through shock before. You guys had that in first module. You should understand what it is. This should be a review. Fair enough? You guys all know what I think of these slides. So it is there for your reading and entertainment and adjusting those down. It probably is important somewhere in time in life. For me, not as much. So, all right. Cardiogenic shock, the body's trying to compensate by increasing the contractile force, right? It's trying to get over that. It's trying to improve the preload, improving preload, reducing the peripheral resistance, or basically all three. This is the big way that we're going to try and compensate. The stroke volume times the heart rate is your cardiac output. Again, that area, I'm going to go right here to this. This area seems to be a repeating series of questions on multiple tests. So if the heart rate isn't able to compensate much, how else are we going to compensate with it to increase our cardiac output? Stroke volume. And how do we increase the stroke volume? Contractile force. Dopamine can be one on there, different things there. So those are things I want you to be thinking about. The body is trying to compensate, and in the aspect of trying to compensate, sometimes it can actually make things worse. So we talked about different ways in this previous slide that we were going to do it. Improving preload. How are we going to improve preload? What's that? Fluids. Fluids can help at a certain time. We don't want to do tons of fluids. Actually, in most cardiogenic shock, we do less fluids. But we're going to talk about other things, too, that we're going to do to try and improve our preload and improve our vascular resistance at times, too. But sometimes, again, by increasing the peripheral resistance, and we're decreasing that, the body's going to compensate by increasing the blood pressures. Kidneys start working, which basically increases the myocardial workload, which is part of our problem, right? And affects that area, and then cardiac output ejection fraction is further decreased. So our body sometimes is trying to fix itself. It can actually make more problems on itself. So what causes it? Again, chronic theme across this. Left or right-sided infarction. The anterior MI is usually causes about 40% of the damage. That's the most prevalent cause with these areas. Again, why an anterior MI? Dealing with the left ventricle. Our left ventricle is our biggest muscle. It's our biggest force, and it feeds our body. So that's kind of the area. When we get CHF that keeps getting worsening on the acute phase, but normally on the chronic phase, that's going to basically cause cardiogenic shock, contusion to the heart, massive pulmonary embolisms, which again cause workload on there. Tension pneumothorax. Why would a tension pneumo do it? Exact same thing. It's putting pressure onto the heart. It's actually squeezing it in, kind of like we talked about when I talked about the pseudo cardiac tamponades. End-stage cardiomyopathies, congestive heart failures, arrhythmias, myocarditis, all these things in here. Obviously, cardiac arrest. So maybe know some of these causes are going to be contributing factors for cardiogenic shock, in case they're saying name 3 or 4 causes of cardiogenic shock. It doesn't occur by itself. It's always secondary to some other aspect. So what are some of the causes? Give me 3 of some of the other causes. Might be something you see in written format in another day. Fair enough? And can you guys see a reason why each of these would cause those? Okay. That's where I want you to know, just know why, But I want you to see reasons. Why would COPD and asthma cause it? Why would hypertension cause it? Why would diabetes cause it? Why would a cardiac arrest cause it? And why would acid-base imbalances? I want you to be able to think the reason. I don't want you to just memorize this. You can just memorize it and you'll do well in the test. But I want you to be thinking of those causes. So when you see something like this, you're like, okay, what could potentially cause that? Hey, if you got a history of diabetes and hypertension, or maybe I'm going to look at their meds and see if they're on lisinopril, on their metoprolol, or are they on other aspects that are doing those things. So I want you to be thinking by the reasons of why you have them.
On that,
yeah.
How would you get diabetes?
How would you get diabetes?
No, how would you get the cardiogenic shock from diabetes?
How do you think? What are some?
Sugar in the blood is uncontrolled.
Acid-base balances are going to cause it. There's a lot of different aspects from the diabetes going through. Who else wants to participate in this arena since we brought up the question? What else do you think? I want you guys to think this one through.
They don't take care of themselves. They get hyperkalemic and all
They
kinds
get neuropathy. I mean, I know of its feet, but you would get neuropathy of other arteries.
It's a small vessel disease.
Yeah.
So it actually gets destruction of small vessels. You get a closing. Small vessels will close off. You'll get neuropathy throughout the area. This is why we talk about silent MIs in that too, because it actually kills nerves to the heart, which can cause basically like a CHF and function on how it's beating. So there's lots of different aspects they can do besides breaking down blood vessels, all sorts of aspects. So it's a general term of things, but those are some of the reasons that it causes. But depending on too high of areas, it does throw off and cause an acidosis. Presentation is going to be different each time. There's no classic presentation. Again, you're getting shock from, and you're basically relating it back to some cardiac type of symptom that's going through. We talk about the different type of shocks. This is one of those areas. What type of shock would this fall into? What is it similar to? Is this its own?
Yeah, cardiogenic.
Fantastic. So you got to be able to see the symptoms of what you're going to see. So when you see something from shock-wise and you see there's a low blood pressure, how are you going to determine cardiogenic versus hypovolemic versus distributive versus neurogenic, which gets informed in the areas too. So I want you to see how it's going to present. Mostly, though, you're going to see this secondary from finding out that the cardiac issue or other things you're going to come into. It's not going to be the typical presentation we'll see across, but it's going to be coming in from other aspects. And anytime we're dealing with cardiac pain, it can be described several different ways, including the fact okay, I have no idea what happened there. I've lost my screen on this side, so that's fun. So including the fact that they can present with no pain at all. They can be into a neuropathy type pain. So I'm going to see if this advances to something I can see. Okay. I still can't see anything on my set, so we're going to go off of this side here. So presentation, signs and symptoms of pulmonary edema. Did I switch on here? Okay. Sorry, I'm getting my areas off here. So signs and symptoms of pulmonary edema: difficulty breathing, diminished breath sounds, rowels, wheezes, crackles noted, productive cough, blood-tinged sputum. This should be a gold standard. Click these back and forth. You see blood-tinged sputum, pink, frothy. You should be thinking right away, popping in your head, pulmonary edema. And these patients, if you ever see that, if you do any type of walking, moving them, as we were kind of talking about before, you can basically throw them to completely unresponsive into a flash pulmonary edema. Other aspects we're going to see on this: persistent hypotension. Why are we going to see that? Heart's not beating effectively. From those aspects, we're not popping up, we're not building up that area on there. We're going to see narrowing pulse pressures could be potentially one of those signs there too, because cardiac tamponade is going to cause cardiogenic shock. So be thinking of all these different things that we can see. They're going to present atypically and all different depending on what's the cause of the cardiac issue. So there's not one constant thing that you're going to be seeing out. The typical rhythm that you're going to see on this, sinus tachycardia, right? Why is that? Again, we're not getting adequate cardiac output, right? How do we fix it? Heart rate is one of the ways. So our body's always going to try and be compensated for these things. Level of consciousness, again, these patients are definitely going to be altered. Why is the aspect on it too? Again, decreased cardiac output, decreased flow to the brain. Could be associated with nausea and vomiting, could have low urine output, they could present cool diaphoretic NASH. All these things can be general. Where I want you to be talking about as far as presentation, typically hypotensive, they're in cardiogenic shock, pulses being weak or absent, and being in a fast rhythm with possible altered level of consciousness are the big things I want you guys to know. How are we going to manage this patient? We're going to usually sit them up. Most of these patients are going to be worse laying down. We're going to get them up. We're going to be considered CPAP if we have any pulmonary edema and for breathing on areas. Otherwise, if we're not on there, we're probably going to go 15 liters non-rebreather. But we're going to be prepared for these patients if they're altered or unconscious to be able to take their airway. We're definitely going to want a 3-lead on this. We're going to want capnography on there to see how they're doing, to adjust how their breathing is going to be doing. And we'll be monitoring their SpO2 as well. So once you've got them intubated, there's always potential, and there's not enough science behind it, but that's also going into the science I was talking to you about, the new resuscitation things they're hoping to have presented in 2020, where they actually show doing CPR at an elevated 50 helps with filling that. So there definitely could be some science behind it, holding that up for dependent position.
That's a really big patient. You get a lot of adipose pushing on it. You can have multiple factors. You get full lungs, a lot of adipose. They're laying down. It's hard to bag. There's that potential where they might bag easier for someone.
Absolutely.
Comfortable sitting up, breathing normally, sitting up. Why not do it?
Yeah. Typically, obviously, usually lay them flat for our ease and position-wise of getting the tube. But after you get the tube in place, if you can bag them manually in there. Yep.
What are your, what are you looking to attain, or do you have a low SpO2 that you can't get up? That would be an indication for me. That's what I consider. Why am I setting them up? Is it just because I think it might be better, or can I document how it's going to be better? That ease of bagging, my SpO2 decrease, so I'm getting good insight. So if I set them up.
Other aspects in here, again, it depends on the cause of what we're going to be doing. We talked about aspirin if there's associated chest pain, if we're thinking MIs, we're thinking issues on there. We always want to get IVs in place. When we consider large bore IV, what do you guys think when you see large bore IV? Yeah, so 18, 16, 14 on there. The difference between an 18 and a 14 is probably when you're dealing in a 30-second period, it could be 10 cc's different on there. So you could calculate that over a larger time frame. 20 cc's a minute. How many is that? That's 120 cc's an hour. Bigger difference between a 14 and an 18, but that's roughly about those areas. So be thinking about that. But an 18 gauge, is that adequate? Absolutely. But that's where I look. When I look large bore, I'm 18 and above. Doesn't have to be a 16 and a 14. Think about different aspects. Again, when we're talking about pressors, know the indications of why you're using it, what the rate you're going to do it before you use it. Consider activating, again, depending on what's the aspect, and obviously high flow diesel is going to be a big thing for us. In hospital complications, again, all of these type of things can definitely happen. These can happen to us in the field as well. Shouldn't be anything new for me from that standpoint. And lastly, once we get in hospital, these patients are usually going right into the cath lab, going in for radiographic dyes, going in for their aspects to see what we're going to see as far as blocking for MIs in there too. One of the big things, I don't know if you guys who are on AMR are transporting much to Deaconess. The new doc who's in charge of Deaconess Cath Lab is trying to get it to the point where you guys can do straight admit to the cath lab. So Sacred Heart used to do it too. Yep, and it used to be times you drop off and go straight into there. So that's kind of the goal for a lot of these now, is to skip ER, skip admit, and they do the admit actually in the cath lab. So, all right, questions on cardiogenic shock? Like I hit the highlights. Let's take another. Let's try and be back at 35 after. I know it's only about 7 minutes, but 35 after, I'm going to start on the next one, hypertension, so we can try and be done at noon and give you guys a lunch.